Good afternoon, everyone, and thanks so much for joining us for today's session of the CRISM Addiction Rounds series. Our speaker is having technical difficulties, so we're just going to ask for your patience for a few more minutes until we can get Dr. Kahan logged on. Thanks so much.
Hello. Can people hear me? I'm
Perfect.
very sorry about that. Anyway.
No problem at all. If you're ready, we'll get started if that's okay.
I'm ready.
Okay, fantastic. Welcome, everybody. My name is Catherine Dong. I'm an addiction medicine physician in Edmonton. Thank you so much for joining us for today's session of the CRISM Addiction Rounds series. Please note that this webinar is being recorded and will be posted on the crismprairies.ca website. I would like to open our session with a territorial acknowledgement. The Canadian Research Initiative in Substance Matters has members from across all of Turtle Island, the land now also known as Canada. We acknowledge that Indigenous peoples are the traditional guardians of this land and respect the sovereignty, lands, histories, languages, knowledge systems, and cultures of First Nations, Métis, and Inuit nations. Ongoing criminalization, discrimination, and institutionalization of people who use drugs has disproportionately affected Indigenous people. As such, we commit to ensuring that this series is anti-racist and anti-colonial and serves as one way to dismantle colonial structures that contribute to ongoing oppression. If you have questions during this session, please use the Q&A feature to send questions to the hosts and panelists at any point during the session. The last 15 minutes will be reserved for questions from the audience. We really value your feedback. This is a new series, so please complete the series evaluation, which you'll receive by email after the session. Completion of this evaluation will also allow you to request a certificate of attendance for your records. Now it gives me great pleasure to introduce our speaker for today. Dr. Kahan is the Medical Director of the Mentoring, Education, and Tools for Addiction Partners in Health Integration, or PHI program. PHI provides education and oversight to Ontario's Rapid Access Addiction Medicine, or RAAM clinics. Prior to his retirement in 2023, Dr. Kahan practiced as an addiction physician at St. Joseph's Health Centre and Women's College Hospital in Toronto. He has been involved in education, policy, and research in the addiction field for many years. Thank you so much, Dr. Kahan, for taking the time to join us today. I'll turn it over to you.
Thank you, everyone. I'm sorry I'm late. I had some problems signing in, but I'm very glad and thankful that you invited me to these rounds. CRISM is an important organization that's contributed a lot to guidance and education and research in substance use. So thank you. Next slide. I did receive an honorarium from Indivior for a presentation last October. Next slide. The learning objectives are to describe the rationale and core principles of Ontario's rapid access addiction medicine clinics, to describe PHI's role in supporting these clinics, and describe PHI's approach to education and advocacy. Next slide. So first I'll start off with RAM clinics, a description. Next slide. To start off with, RAM clinics started in 2012, and at the time, and things haven't changed that much, they have improved somewhat. There were real problems with the addiction treatment system. For example, opiate agonist treatment clinics were mainly private fee-for-service clinics that provided medications through brief office visits, but often with little counseling or psychosocial support. Withdrawal management services lack the healthcare staff to offer medication-assisted treatment, either medication-assisted treatment for withdrawal or opiate agonist therapy or anti-craving medications. There were restrictions to entry for psychosocial programs or waiting lists and medication restrictions. And perhaps most importantly of all, addiction treatment remained siloed in specialized clinics, was rarely offered in hospitals or emergency departments or primary care. Furthermore, there was a dramatic lack, and still is, of resources given the magnitude of the public health impact of substance use disorders. So a system-wide under-resourcing. Next slide. So we applied for a grant in 2012 to the Ministry of Health to pilot some RAM clinics in 7 communities throughout Ontario. And the pilot demonstrated marked reductions in healthcare utilization in these patients who attended the RAM clinics. So since then, the Ministry of Health has funded over 85 RAM clinics throughout the province. Next slide. The core principles of RAM clinics are low barrier care. That is, it should be as easy as possible to get care. Comprehensive care, that is, medications and psychosocial counseling are offered on the first visit, and all substances are treated, alcohol, opiates, cannabis, etc. Integrated care, recognizing that RAM clinics can't offer all treatments for everyone, so they're part of an integrated care pathway with emergency departments, withdrawal management, primary care, and other community addiction and mental health services. People-centered care, this is not kind of protocol-driven treatment. There's no single treatment approach that works for every individual. Next slide. The description are that RAM clinics are staffed by at least one prescriber, that is a nurse practitioner or a physician, and a counselor, an addiction service worker or peer worker or case manager or social worker, etc., plus other allied health workers, RNs, and RPNs. Treatment, again, is provided for all substance use disorders, although alcohol is number one, with opiates being a close second. Patients can be seen without a referral or appointment. They can drop in, and treatment is offered on the first visit, counseling and medications when appropriate. People are connected to community services, and their patients are followed until they are stable and can be transferred back to primary care or another service. Next slide. The effectiveness of RAM clinics, and it's important to emphasize that there aren't sort of unique interventions in the RAM clinics. This is a service delivery model, so that opiate agonist treatment is offered, anti-craving medications, counseling, etc. So a matched case control study showed of the RAM clinic in the Royal Ottawa Hospital, which is affiliated with their emergency department, showed that patients who had an opiate use disorder who attended the RAM clinic had an improved composite index of mortality and healthcare utilization compared to matched controls with opiate use disorder who didn't attend. Retrospective cohort studies and patient surveys have shown that, according to self-report at least, RAM clinic attendance is associated with marked reductions in substance use and reduced ED visits. A controlled trial that looked at the concept of same-day attendance found that patients who were in the withdrawal management service with an alcohol or opiate use disorder, withdrawal management service in Toronto, were randomized to receive either usual care, that is, here's the phone number of a RAM clinic near you, versus same-day attendance at the RAM clinic, and at 6 months, they had decreased ED visits. That is, the same-day attendance group had decreased ED visits. It's also clear that clients are satisfied with RAM care. They like the fact that there's no waiting, and they feel there's less stigma versus usual addiction services. Next slide. RAM clinics, it has to be emphasized, are basically designed and operated by the local community, people in the local community, administrators, clinicians, counselors. They're given some funding from Ministry of Health, usually for a support person like a counselor, and the rest they do themselves. They find the location, which may be opportunistic location in a withdrawal management service, in the local Canadian Mental Health Association, in a hospital, and then they find staff that are often funded or seconded from another service to cover everything. They are often very innovative in order to overcome geographic challenges and funding limitations. So they often rely on virtual care, or they may have a hub and spoke model of care, or mobile clinics. They rely a lot on partnering with community services, and there is a team approach to care. Next slide. So how does Medify fit into this? Next slide. A Medify is funded by the Ministry of Health. We're a small group. I'll show you a picture of us. It's just about 5 staff. We provide education and support and advocacy for the RAM clinics, but we're not directly responsible for funding them. Next slide. So how we support them is, and I'm going to briefly mention these, we have the RAM Clinic Quality Targets document, a toolkit, an annual survey, a community of practice, and educational and clinical materials. Next slide. So the RAM Clinic's Quality Targets document outlines the aspirational goals of RAM clinics. We recognize that not all RAM clinics can meet every target, but this is what RAM clinics are aspiring to do. So target 1 is that access to care is timely, and that means that the clinic has drop-in hours, and the schedule allows patients to be seen or clients to be seen within 3 days. Target 2, and unfortunately I repeated this twice, is that an appropriate range of services are available. That is, the clinic offers pharmacotherapy and psychosocial support, and harm reduction and peer support. Next slide. The RAM Clinic Toolkit is designed specifically for administrators and leaders and clinicians of the RAM Clinic. And that's because the RAM clinics are relatively new and they're based on a different model of service delivery. And also that RAM clinics have limited funding. So there's a lot of kind of improvising and challenges going on that way and forging partnerships with local services. Next slide. This is a list of all the things that are in the toolkit. By the way, at the end, we have a, what do you call that? Those things where you can click on to the Medify website and get all these materials to download yourself or to view them on the website. So the toolkit has everything, an introduction to the RAM clinic model, how to start a RAM clinic, RAM clinic human resources, quality targets, transition planning, how to connect patients once they're stable to another service, clinical and administrative policies. Next slide. We also have an annual survey. And this is a very detailed survey. It takes a bit of time for people to go through. It offers in granular detail. It asks administrators about what services are provided in terms of medication, harm reduction, supplies, etc., psychosocial support. What are the hours of service, whether they're drop-in versus appointment, virtual or in person, the staffing that the RAM clinic has, NP, counselor, physician, and so on. and also how they manage concurrent conditions such as hepatitis C and mood and anxiety disorders, and the availability of supplies. Next slide. The results, we get really excellent response rates, even though it's a difficult survey to complete. The large majority of RAM clinics are meeting their targets. Respondents are reporting great satisfaction with the interprofessional team approach. That is, patients, client counselors and physicians and NPs are working together to meet the needs of the client. It's not sort of it's not rigid rules. And from 2022 to 2025, RAM clinics have expanded in number and the range of addiction medicines prescribed medications. Next slide. There are areas needing improvement. For example, maybe only 60% of the RAM clinics prescribe methadone. Buprenorphine is universal, but methadone is less common, and SRAM, or slow-release oral morphine, is less common. And not all clinics distribute harm reduction supplies. They all distribute take-home naloxone, but they're not as likely to distribute inhalation and injection equipment. We have been trying to address that with written documents and webinars and distribution of informational bulletins. The main problem that most RAM clinics identify is that they have limited hours due to limited staffing, and that's a major barrier to RAM care. They mainly report difficulty recruiting physicians. Physicians are only funded through fee-for-service, and there's easier and more reliable ways for addiction physicians to make money than through a RAM clinic, mainly through a community OAT clinic. Medify is using the survey results to advocate with the ministry for more funding for in-person and virtual care. Next slide. Another way we support RAM clinics is through a listserv where anybody can email a question or make a comment. We have more than 1,500 members, mostly from Ontario, and they have a broad range of backgrounds: physicians, nurse practitioners, social workers, counselors, people with lived experience. There are multiple posts a week and on a variety of topics. Some may be simply requesting assistance for a patient who's moving. There's also clinical questions about medications, etc. There's discussions about policies and issues such as the closure of supervised consumption sites, announcements about events and publications. The listserv has been an important our connection to the field, so to speak, has alerted us and others to issues that require advocacy. Next slide. We also have other communities of practice, webinars, dialogue calls, town halls. We have monthly accredited webinars with invited speakers. We have monthly calls that are more free-flowing. We have what's called the dialogue call, which is case discussions. We also have an addiction nurse practitioner call, which is led by Katie Dunham, where there's substance-related concerns and discussions. And then quarterly town halls for RAM clinic administrators and clinical leads, where we spotlight innovative programs and roles such as peer workers, mobile clinics, and virtual care. Next slide. And then we have our annual conference. This is entirely virtual, although there are in-person social hubs at selected places throughout the province. The attendance is pretty good. It's over 350, the last one, and they're from all regions of Ontario. It's a low cost and a wide representation from different professions and a wide range of topics, clinical, medications, psychosocial, and it's also an opportunity for to showcase RAM Clinic's innovative practice. And Katie makes a comment. If anyone is welcome to attend any of these events, then you can email our network administrator, Laurie Smith. That's laurie.smith@wchospital.ca. And I'll have emails at the end. Next slide. So Medify's clinical and educational publications. Next slide. So they are, there's two things that are sort of different perhaps about them. One is that our materials are often designed for specific settings, such as the emergency department or the RAM clinic or the withdrawal management service or primary care or residential programs. And the reason for this is that, it's one thing to have a guidance document on management of alcohol withdrawal with symptom-triggered treatment, but how does that apply to primary care or the emergency department or the RAM clinic, which doesn't have the resources of the emergency department, or withdrawal management settings, which may not have a prescriber on site, or a nurse even on site all the time. So you want to have recommendations that are specific to the clinical setting that the patient is in. And also, they're evidence informed. They're not evidence-based. The problem, the substance use disorders have progressed in severity far beyond what the standard clinical protocols are. The methadone prescribing protocols, for example, that were in place for decades, and they simply aren't working as well for high potency people who use high potency opiates such as fentanyl. So sometimes you have to make clinical recommendations that go beyond randomized trials and systematic reviews. They're based on clinical experience and clinical judgment. So the guidance documents that we have produced are very focused on the needs of the clinician. They contain practical clinical tools and resources, including order sets and patient handouts or client-facing materials, algorithms. The tools and the guidance documents are co-authored by groups of clinicians, healthcare staff working in the relevant sectors, such as emergency department or RAM clinics or withdrawal management service, as well as people with lived experience relevant to the specific project. And so we value and acknowledge the different types of experience and education and partnership between all members of the groups. I can tell you, for example, that the methadone dosing guidelines have for many years been very rigid. Start off with no more than 30 milligrams and increase slowly. But if you talk to people with lived experience, they'll say that these protocols are grossly inadequate for what they need and what they needed when they started treatment. The other thing about the guidance documents is that they're intended for clinicians with a broad range of expertise, from the experienced addiction physician to the person who, at the end, nurse practitioner or physician who's just starting off. Next slide. These are some examples for RAM clinics. We have a clinical best practices in addiction medicine, a guide for RAM clinicians. We're still working on an updated version of that. For emergency departments, we have the ED toolkit for opiate use disorder and an ED toolkit for alcohol-related presentations. Withdrawal management services, we have the withdrawal management services toolkit. Primary care, we have a handbook, primary care management of substance use disorders. And we also have, for residential programs, recommendations on the provision of opiate agonist treatment. Next slide. Harm reduction, we have a distribution of safe injection and inhalation equipment in RAM clinics, how to build a take-home naloxone program in your emergency department. And we have a number of client-facing materials, including materials for patients in the emergency department with an alcohol use disorder and materials for patients who are on methadone treatment. Opiate agonist therapy, we have guidance documents on methadone and guidance documents on slow-release oral morphine, and several documents on starting buprenorphine sublingual and starting extended-release buprenorphine. Next slide. So advocacy, we do this through briefing notes, petitions, meetings with key officials. Much of our advocacy is with the ministry, and we do it either ourselves or in partnership with key stakeholders such as Center for Addiction and Mental Health. We are an independent organization, even though we're funded by the ministry. We're allowed to operate more or less independently, and we can speak our mind within the ministry, so that's good. Examples, we were able to get the Ontario Public Drug Plan to make buprenorphine XR a general benefit. We are working with Health Canada and making considerable progress in getting them to amend their regulations so that registered nurses can prescribe buprenorphine. This is critically important in rural and remote areas where RNs are often the main healthcare provider there, and they don't have access to a physician or MP. Along with many other addiction and public health organizations, we lobbied to keep safe injection sites open. We weren't, we did help, I think, delay their closure by a number of months, but ultimately they did close, or many of them closed. Next slide. Services that are funded by Heart Hubs, and that stands for Homeless and Addiction Recovery Treatment or something. I don't remember what it stands for, but these are Heart Hubs that were intended to replace the closure of the safe injection sites. And they're basically a network of RAM clinics and withdrawal management services and other social services. There is this ridiculous policy prohibiting their distribution of harm reduction supplies, and we are working very strongly to advocate for rescinding this policy, but I can't say we're successful yet. When the funding for the Digital Front Door virtual care platform was jeopardized, we did work with the ministry to ensure long-term funding, so that was a success. That's a wonderful platform for virtual care. A lot of our work is centered around the Center of Excellence. That's the ministry's put a lot of funding into building an integrated care pathway between emergency departments and RAM clinics. And we are advocating strongly with them to ensure that RAM clinics are appropriately funded so that they can provide ongoing care for patients discharged from the emergency department. Next slide. In terms of system level change, the Ontario system is, I would say, incoherent in that there's a lot of things that don't make sense, and the parts of the system don't communicate with each other, and there's just a lot of inequities in the system. For example, emergency departments rarely initiate addiction treatment on site. Medify is supporting the COE and building this integrated care pathway. The idea is that the EDs would initiate opiate agonist therapy and anti-craving medications on site when indicated and the patient agrees, with follow-up in the RAM clinic. So we're working with them. We have the clinical and educational expertise. We've been helping with the toolkit, with developing order sets, etc. Next slide. Withdrawal management services, they have limited capacity to provide medication-assisted treatment, a lot better than it used to be because they now are supposed to have at least one nurse practitioner on site, but they still have big gaps in being able to provide, symptom-triggered treatment for alcohol withdrawal, etc. We've done a lot of work with this. We've developed a toolkit on clinical management of substance use disorders and withdrawal management services. And we are training nurse practitioners who work in WMS. So we've done a lot of work with this. The main challenge, again, is lack of health care staff and funding. Similarly, primary care, very few primary care providers prescribe OAT even to patients who are stable. So we're developing clinical tools for primary care. We've submitted a proposal for collaborative care programs. Next slide. In terms of our impact, I think we have had an impact on opiate agonist treatment practice. For example, Medify collaborated with CAMH and the Ontario Medical Association to come up with a guideline on methadone take-home doses. This was around the time of COVID when it was urgent that take-home provisions be more flexible. There have been papers published showing that this has had a big impact on prescribing of take-home doses. We had a guidance document recommending that slow-release oral morphine can be added to methadone, especially early on in treatment in patients who are people who are using high-potency opiates. And there is evidence that a number of clinicians or number of patients are now on the combination of methadone and slow-release oral morphine. I would say it's turning out that nurse practitioners are becoming a backbone or mainstay of delivering addiction, medication-assisted treatment in Ontario. Half of the RAM clinics have nurse practitioners who are prescribers, and most of the withdrawal management services have nurse practitioners who are prescribers. And Medify has helped train Ontario nurse practitioners in addiction protocols. This initiative is led by my colleague, Katie Dunham, who is participating in this workshop. Next slide. So now I get to toot my own horn or our own horn. Why are we doing so well? We are staffed by a very small but experienced and cohesive interprofessional group. And I would say we've been together since 2012. The core part of us, other people like Katie and others have joined later, but we have been together for years. We're interprofessional physicians, nurse practitioners, knowledge brokers, administrators. And so we built up our experience together, and we've also built a large network of people and organizations from different professions, settings, and regions who collaborate with us. We get to decide on our own projects, more or less. Nobody's telling us what we can and can't do. And we are in tune with issues and concerns from the addiction field based on our colleagues, based on the listserv, and we're able to respond quickly with advocacy and education. Next slide. These next 3 slides are the references. Next one. And one more. Oh yeah, okay. So these are our emails. Yeah, what's our barcode? That's what this is called, with a little dinosaur in the middle. So if you look on that barcode, will connect you with the Medify website, and you can see a lot of the materials that we have produced and read more about Medify. Next slide. So there should be some, and here we are. See, as I say, we're a small group. There should be some time for, lots of time for questions and comments and shared experiences. I will just make one last overall comment. The addiction field is in a great deal of, what's the word? Not chaos, but ferment. Things are changing. We have been absolutely, shocked by the severity of the substance use challenges that have come forward with fentanyl and methamphetamine and all these other things. We have realized that what we're doing to date has not worked as well as it should. And there's a tremendous amount of innovation going on throughout the country, in Ontario and elsewhere. And I think it's the challenge for large organizations like CRISM and other organizations to rise to that challenge, to support local innovators, to make sure that everyone who has a good innovation, that the whole country knows about it, and so we can do a better job of meeting the needs of Canadians. So I'll leave it there and open for questions and comments.
Thank you so much for such an inspiring talk, and congratulations on the huge success of Medify. It's really wonderful to see it all laid out. We don't have any questions yet from the audience, which means I get to ask the first question. So I'm wondering, Dr. Kahan, if you can talk about what makes advocacy successful. I agree there's a tremendous amount of advocacy that needs to be done in our field. What's your guidance for making sure advocacy is successful?
Well, a few things. One is persistence, because lots of times things are the way they are just because that's the way they've always been, and nobody knows how to change it. And the people that are responsible for policy may not be all that interested in changing it. So you need to be persistent. don't keep on working on it. Now, Katie and I have been, but especially Katie has really worked on, for example, getting authorization for RNs to prescribe buprenorphine. It makes total sense. BC does it. There's very little, I would say, drawback or harms. We're not talking about hiring 1 million RNs. We're just talking about training, offering training to the ones that are there so that they can prescribe buprenorphine and remarkably safe. But we've been working in a College of Nurses of Ontario and the ministry and the Registered Nurses Association of all these different groups, and you don't get a clear answer from anybody. So you have to be persistent, and you also have to be, I would say, aggressive. If you got a good idea, you just have to keep on bugging people and escalate and use your opportunities when they come up. We've had a fantastic response from Health Canada, from I don't know if we should get into names, but the chief nursing officer, whose name I forget. Katie, what's her name? Can't remember.
Dr. Lee Chapman.
Dr. Lee Chapman has been amazing. So you just have to bug people. You just have to bug people, and sometimes you have to join with community organizations. Now, we're an insider in the sense that we're part of the Ministry of Health, so we don't immediately run to the media and so on. So we're trying to do it through internal pressure, but you can also leverage external pressure to make the kind of headway that you need to do. Now, I must say that we are working in a bad climate right now. Everyone, the economy is not great, and so mental health and addiction are competing with other, for healthcare resources. But still, I think that our success in advocacy has been, again, for persistence and not giving up.
Thanks so much for sharing your wisdom. I appreciate that very much. We do have a question from the audience. With 85 sites, have you learned anything about the best locations or the locations with the best outcomes?
That's a great question. I would say that there are advantages and disadvantages to each. So first of all, these RAM clinics often don't have a lot of choice of where they locate. They don't have the funds to rent an office or something. So they're reliant on partnerships. If they're in the hospital and the emergency department, that's great for emergency department patients because they just have to go down, the hallway to the RAM clinic. So that's ideal for them. If they're located in a withdrawal management center, that's perfect for WMS patients. And so a lot depends on which sort of population you serve. And virtual care is another way to overcome geographic limitations. So I would say that it's a good question, but there's disadvantages and advantages to everything. And a lot of clients, people discharged from the emergency, if you tell them to go to a place, even if it's 4 blocks away, if they've never been there, they're less likely to go because it's not their medical home, they're not used to it, and so on and so forth. So it's a big challenge. And I think virtual care has has a great possibility to overcome these kind of challenges of location.
Great, thank you. Another question from the audience. In your opinion, are there any significant advantages to specialized addiction clinics like OAT clinics over something like a RAM clinic? What is the landscape like in Ontario with respect to specialized addiction clinics?
Well, I think that, one advantage of specialized, methadone clinics or OAT clinics is that they can they're it's easier to provide OAT, I guess, because you have a prescriber there who's very experienced. They have automated systems for faxing in scripts and collecting urine drug screens and all that. But I would say, and this is my own opinion, I would say that the fee-for-service methadone clinics have overall had a negative effect on the provision of addiction treatment in Ontario, in the sense that there's these large chains, profit-oriented chains. I don't think it happens in other provinces, but it did in Ontario. Large profit-oriented chains where they were maximized. They maximized their clinical care and services for profit. So they required patients to attend for urine drug screens twice a week or to see the doctor twice a week because that maximized OHIP billings. And they were the only game in town for many of these communities. So if patients didn't like it, tough. There were always other patients to come to take that place. I think that was very destructive to the reputation of addiction medicine. And sure, they went to a lot of communities that were very underserved, but I think that whole model is not good at all. These patients need a lot more than just a prescription. And aside from that, it's an intrusive kind of care to force patients to come twice a week for a service that they don't need, and they know they don't need it, is alienating and it's intrusive and it's a coercive kind of model of care. Now, and now I'm not saying that every single physician in those treatment programs was like that. There's a lot of great physicians, but they had that model of care, and I think it needs to change, and probably is changing now with the introduction of RAM clinics and also the introduction of independent OAT clinics where they're a lot more patient-centered. But Katie has a question or a comment.
Just to add to that one, that one of the downfalls that patients see that have gone to those clinics or are still at those clinics but access RAM is that substance use isn't frequently a one-off. It's not, clients use more than just opioids most of the time. So if you purely and only use opioids, then an OAT clinic or an addictions clinic that prescribes just opioid agonist treatment is right for you potentially. But if you use alcohol or you need help with tobacco or cannabis or any kind of stimulant, those frequently aren't addressed at clinics that provide just opioid agonist treatment. And we have many clients that actually attend both their clinics and ours because they do need assistance with alcohol that isn't being addressed there. So pros and cons again.
Yeah, great. Thanks for that. And it is interesting how things are different between the provinces. One other question. What would you like to see RAM clinics focus on next?
Well, I think that there's a number of issues. One is that they're going to have to focus on emergency department patients and be open for that. So they are going to need more funding. I think they need to be available for youth. I think of all the kind of groups, and I guess every group has been harmed by the substance use crisis, but youth have perhaps the greatest harms. If you look at in Ontario, a study found that even though the prevalence of opiate use disorder and the prevalence of opiate overdose has exploded among youth since from late 2010 to now, the number of people on OAT, the number of youth on OAT has actually declined. So we are not doing a good job with engaging youth in treatment. We need more youth-specific protocols. Some of the protocols that we have for youth are simply, they may be okay for adults, but they're not good at all for youth. And in fact, some RAM clinics don't even want to see young people. A lot of RAM clinics are not, they don't know how to manage cannabis use disorder, and they just are not sort of equipped or interested in offering services for youth. There are some youth-specific RAM clinics, and that's great, but we need a lot more. So we also need, I think, probably greater outreach for RAM clinics for Indigenous populations, not just in, sort of First Nations communities, but also for Indigenous populations in larger urban centers like Toronto and Thunder Bay and so on up north. So those are some of the things we need to concentrate on in the future.
Thank you so much. And one last question for me. Your thoughts about structural change. A lot of what you've done is really change how care is delivered, which is very challenging to do. Very difficult to change the healthcare system and the structure of the system. What's your advice around making that type of structural change?
Well, I think that it's probably beyond individual addiction clinicians, and it's a matter of political will. I think if you look at hospitals and emergency departments and so on, they're little fiefdoms. They have a lot of money, and the people that make the decision in hospitals and EDs are not necessarily interested in addiction. They have their other things that they're very interested about. They're tiny little political organizations. And I think that what is needed is the political will to tell hospitals and emergency departments and primary care even, we will give you the appropriate funding to offer these services, and you have to offer them. We don't care whether you hate these patients or don't like them or think something else is more important. You are going to offer them. Just like when we give you the flu shot, we expect you to offer the flu shot. This is a matter of political will. We saw it with COVID. I was around when COVID was there, and hospitals introduced new protocols and reorganized services and rotations and everything else overnight. Substance use, I think, from a societal perspective, is a far greater problem than COVID was. And we haven't put anywhere near the resources into it. So I think it would take political will ultimately. But I think we can all take a lesson from the HIV field many years ago. When HIV was, killing, people were dying from it, and there were no treatments available. The HIV community that both patients and clinicians banded together, and they made a lot of noise. That resulted in a very major investment of funds into research and so on. And it's so frustrating because we have effective protocols. It's not like, we don't have a way to treat addiction. We do. There's a lot that we know about it and a lot that could be done. Why is it that in Ontario, only 5% of patients with an opiate who presented to the emergency department with a life-threatening problem like opiate overdose were offered OAT within 7 days of discharge from the emergency department? Like, it's unacceptable. There's a lot of work that needs to be done, but a lot of it is just the addiction field banding together, standing up for what is right and making a noise.
Thank you. Yeah, still more work to be done. We're so grateful for your time. Thank you, Katie, also for joining us, and Dr. Kahan for your words and your presentation. We're really grateful. So thank you very much on behalf of CRISM. I'd like to remind everybody that our next webinar will be on November 19th, and we have Dr. David Crockford presenting on the Alberta Compassionate Intervention Act. So with that, I'd like to thank everybody for your attendance today and wish you all a fantastic rest of your day. Thank you.
Thank you all.